welcome all of you to this Respect Center sponsored program. I'm Joan Haase. I'm one of the co-directors of the Respect Center, which is the Research in Palliative and End-of-Life Communication and Training Center. It's an IUPUI signature center. The other folks who are co-directors with me, I'd like to recognize Greg Sachs and Susan Hickman, my co-directors for this wonderful group of people. A couple of announcements. This lecture is being recorded and broadcast today, and so thank you for those of you who are at IU Health Ball Memorial for joining us from that site. We ask you all to please silence your pagers and electronic devices, and if you need to return a call, to leave the auditorium to do so. It's my great pleasure today to introduce you to Dr. Joanne Wolfe, who is the Chief of the Division of Pediatric Palliative Care in the Department of Psychosocial Oncology at the Dana-Farber Cancer Institute. And actually, she's the acting director of the Department of Psycho-Oncology at this point as well. And she's an Associate Professor in Pediatrics at Harvard Medical School. She holds her MD degree from Harvard Medical School and an MPH from the Harvard School of Public Health. The Pediatric Advanced Care Team, the Palliative Care Service in which she directs, received a 2001 Citation of Honor from the American Hospital Association Circle of Life Awards program for its innovative approach to caring for children with life-threatening illnesses. So very well recognized for the wonderful work that she does. Dr. Wolfe developed the first interdisciplinary pediatric palliative care fellowship program in North America. She co-developed the pediatric track of the program for palliative care education and practice, a continuing medical education course offered through the Harvard Center for Palliative Care. She's also a co-investigator on the EPIC Pediatric Project, an online and face-to-face curriculum which aims to enhance primary pediatric palliative care knowledge, skills, and behaviors among pediatric clinicians and subspecialists. Dr. Wolfe's research is focused on easing suffering and promoting well-being in children with serious illness and their families. She co-directs an emerging pediatric palliative care research network, Peppercorn, which I think is the coolest name. Dr. Wolfe is the recipient of the 2013 American Cancer Society Pathfinder in Palliative Care Award and the 2014 AAHPM Award for Excellence in Scientific Research. So please join me in welcoming Dr. Wolfe.
Well, thank you for that introduction, and I'm really, really grateful to be here. Love to know a little bit about who you are. I'm not going to have everybody introduce themselves, but if you can tell me if you primarily take care of children or study children and their families, if you could raise your hand. Great. So those of you who aren't, can you raise your hands? Okay, just getting a better sense. And anyone who is in primarily hospital-based practice? Great. And home-based practice? Not too much. Okay. Now, among those of you who don't participate in the care of children or study children, how many of you have distress over the prospect of taking care of children? Be honest. All right. Well, good to know, because I have one piece of advice for you. Get over it. Because no, they're not little adults, but they're in need of care from all kinds of providers, because there are not enough of us who specialize in pediatric palliative care, and so we have to work together as a community and learn from one another. And I'm looking forward to talking to everyone, no matter what your background is. So let's see. I don't have anything to disclose. And what I hope to do in the next 45 minutes is describe some principles of pediatric palliative care that underlie our research program, to describe a framework of family suffering and potential interventions to enhance well-being in families of children with serious illness, and to identify some outcomes of our pediatric palliative care research program. Now, I hope this is familiar to most of you. Everybody has their different models of palliative care. For me and my team, clinically and research, palliative care is an individualized blending of care directed at the underlying illness and the physical, emotional, social, and spiritual needs of the child and family, with continuous reevaluation and adjustment. It's a process. It's about longitudinal involvement. It's not at all stagnant, and it's delivered by people who are within interdisciplinary teams in subspecialties like oncologists and oncology clinicians, or pulmonologists and other pulmonology clinicians, or by subspecialty teams. And what we've learned from our research is that this approach enables an integrated, blended approach to the care of children with serious illness and their families, because families, and in particular parents, our research suggests, hope for cure, hope for life extension, or even a miracle up until the last breath of life, and that's innate, normal, acceptable, not something to be fought against. And at the same time, they hope for comfort and meaning. It's not an either-or approach from the perspective of our families, and nor should it be an either-or approach for us. Now, I put end-of-life care as a somewhat different period, although very ill-defined, when I think that almost all care is directed at ensuring the comfort of the child and family. And by end-of-life care, it could mean a period of moments when a decision has been made to discontinue a ventilator in the neonatal intensive care unit, and the expectation is that child won't survive but a few moments, or maybe hours, or sometimes longer, because babies are resilient, as are children. And so we might be in this end-of-life care period for just a short period of time, and then if the child survives, we might be back in this more long-term care of a child and family if they keep breathing and they show us that they can feed and they show us that they can grow up a little bit. It could also be a period of time, say in cancer care, where a child is continuing on some sort of oral antiangiogenic agent with the hope of controlling the cancer for as long as possible, because that's what's most important to the child, to the parents, and maybe the oncology providers as well. But at the same time, they're home with hospice care, and there's a very intensive focus on their quality of life outside the hospital. Sometimes people think of that period of time as palliative care alone, but really what we're hoping to do through our clinical work and our research is to enhance care all along this illness experience. And of course, bereavement care begins well before the end of life of a child. What we do, and data are emerging that suggests this very strongly, what we do ahead of time for patients and their families can make a big difference for the bereavement outcomes of children like siblings and their parents. So that's our model of pediatric palliative care. Early on in my research career, and I was talking about this this morning, I used retrospective methods, looking back on the experience of children with cancer at end of life, and the reporters for those studies were primarily bereaved parents. Now my aim is to do prospective research and try to better understand the experience from all members of the family and care team. So examples of some of the very early studies were a single center cohort study of bereaved parents who were invited to answer a comprehensive survey face-to-face or by telephone on average 3 years after the death of their child. We started this way because in order to be able to get a baseline of how we were doing in pediatric end-of-life care, so it's end-of-life because it was looking back at the end-of-life period, we couldn't do that as easily prospectively. So we decided to invite parents back to talk about their child's illness experience and their family experience. And we got a really wonderful response rate and a lot of participation from families who said to us, "What took you so long to ask?" In any case, unfortunately, we uncovered some room for improvement. In the last month of life, parents reported many common symptoms like fatigue, pain, shortness of breath, poor appetite. And in the most common symptoms, over 50% of the time, these red bars signify that parents reported that their child experienced a lot or a great deal of suffering from those symptoms. And there are other data from this study that said that efforts to treat some of those symptoms were limited and often not successful, in particular when it comes to fatigue, which we're starting to think more about. Fatigue is sort of thought of as an expected outcome of advanced disease, as opposed to thinking about it as a differential diagnosis, as a sort of a symptom that emerges from a multitude of factors. We also found some improvement needs with regard to communication. This study asked parents about the time they came to understand that their child had no realistic chance for cure, and we compared that to when physicians came to understand that outcome. And if the average duration of the child's illness was about 32 months, physicians came to understand that the child had no realistic chance for cure about 7 months on average before death, and parents came to that understanding in half the amount of time. Now, I don't show the data here to suggest that perfect overlap is what we should be striving for. We don't know, but we do know a couple of things. One is that that overlap was closer aligned when there was a psychosocial clinician involved in the care of the child, suggesting perhaps an interdisciplinary approach to care might be a good way to go. And if the physician and the parent came to the understanding that the child had no realistic chance for cure early on, there was more likely to be a focus on easing suffering as the primary goal of care within that patient population, and other outcomes like resuscitation status, death in the ICU was decreased, and more likelihood of involving hospice as home care. So there's some changes in the quality and patterns of care that might happen with better alignment of understanding of prognosis. So what are our pediatric palliative care core ideals? And our service emerged from these baseline data, giving us a mandate to try and make a difference. Of course, again, this is probably all new, all familiar to you. The idea of a palliative care team is to work together as an interdisciplinary team, that the team should be patient and family focused. The idea, as I discussed previously, is to identify and re-identify goals of care. Care should be along the continuum. There should be intensive symptom and psychosocial and spiritual support, and a lot of self-care for us as providers, all to create meaningful experiences for the child and family and us as clinicians. From a research perspective, we sort of embrace these values. We work as an interdisciplinary team. We are in partnership with patients and families. We are always reevaluating the primary focus of our research agenda, thinking about various settings to conduct our research. We are looking at symptom outcomes, psychosocial and spiritual outcomes, and also think about our own self-care as a research team, all with the goal of creating meaningful research. And the interdisciplinary team in clinical practice involves often at the center of the team, the patient and family, physicians and nurse practitioners, administrative support, chaplaincy, psychosocial clinicians, pharmacies, community providers, schools, et cetera, et cetera. And in research, we have physician and nurse, and administrative and informatics scientists, and psychosocial investigators, and social scientists, and biostatisticians in partnership with patients and families. And of course, key to the success of research program is collaboration. And I had the good fortune of having early opportunities for collaboration because people were very interested in this work. And the collaboration has led to an emerging research network that we do call Peppercorn. But there's the Academy, there's the International Children's Palliative Care Network, the American Academy of Pediatrics, sort of like a broad mandate now to consider this work as a high priority. And then there's mentorship as a key to success, both clinically and from a research perspective. And I just want to take a moment to acknowledge my primary mentor, who is Dr. Jane Weeks. She died a little over a year ago, and I am continually impressed by those that she impacted, primarily through research, but that research has had such a significant impact for many families and will do so for many generations to come. And then I had mentioned that there's primary and subspecialty palliative care. The idea that all clinicians should have basic palliative care skills, and I have been learning about so much incredible work here, trying to enhance the skill sets of clinicians throughout the healthcare system with regard to, for example, communication, and just having a comfort level with conversations that are all too often made into very complex confusing dialogues between providers and patients and families, and yet here across your institutions there's a commitment to enhancing primary palliative care skills, and that's remarkable and innovative and incredibly beneficial to patients and families. And then there's subspecialty palliative care, which is what I do. I have a mandate to provide consultation not to everyone who has a serious illness, but in more complex clinical situations, to educate and train. As noted, we have an interdisciplinary fellowship program, and to conduct innovative projects and research. So that's what a subspecialty does. It doesn't mean that you have to take over care, but you do it in partnership with your constituents. So I want to shift gears. That's sort of the background and our philosophy of sort of how we put ourselves together as a research team, but I want to sort of think about easing suffering as a goal of a research program. And I found that the words of Eric Cassell, by the way, anything he's written, and in particular this comes from his book, The Nature of Suffering, are so profound and insightful and really do form a foundation for our research program. Eric has written, "Suffering is a specific state of distress that occurs when the intactness or integrity of the person is threatened or disrupted. It lasts until the threat is gone or the integrity is restored. The meanings and the fear are personal and individual, so that even if two patients have the same symptoms, their suffering would be different." To me, this suggests, who are we to judge whether someone is in distress, right? That has to come directly from the patient, and we need to uphold their view of their illness experience and try and mitigate it. So taking that profound statement and trying to put it into a framework of easing suffering in pediatrics, we think of a family as coming into an illness experience with their own family integrity. And there's a lot of, this is sort of as an aside, a lot of complexity to taking care of families, as we know, and whose interests do we hold as primary. For me, families, the goal of palliative care is to maintain the intactness of that family, not to disrupt it, and not to change the culture of a family, but rather to support the culture that the family comes to you with as they present with an illness. And that family often consists of parents and siblings and the patient, and could be, all kinds of different families. And then you have the illness experience that either happens at birth, prenatally, at some point in childhood, like the diagnosis of cancer or the uncovering of cystic fibrosis or a congenital heart disorder, for example. And because of that illness, there's family suffering. There are visible threats. The life-threatening illness itself, as soon as a family hears that a child has cancer, what is the biggest worry on their mind? The big elephant in the room that is what they're petrified about when you say your child has cancer. That the child is going to die, and yet it's practically the last thing we typically talk about. But that message is completely about, is my child going to die? That's the first thing that comes into any family member's head. The symptoms and the emotional factors that emerge from the illness, and then the invisible threats, the disruptions from normal life, emotional and existential concerns, spiritual concerns, and then the pre-existing and developing sociodemographic concerns that emerge throughout the illness experience. And so to ease suffering, we need to consider targeted interventions and global interventions to try and sort of ease that suffering with the hope of restoring some form of integrity for children, families, siblings. It won't be the same as it was before, but we want to do restorative work through our palliative care clinical interventions, and our research interventions should be aiming to achieve the same outcomes. So I'm going to share with you some of the wonderful work from my mentees who both are contributing to sort of the details or the nuances of this model and working together with me to try and get to those interventions as well. And this is Dr. Christina Ulrich, and she took one of our data sets. This was from the perspective of bereaved parents, and I was talking to you earlier about the multifactorial aspects of the fatigue experience, and looked at factors that were related to having fatigue and high suffering from fatigue. And you can see that if you were in pain, if you were short of breath, and certain different elements of that, even the treatment of shortness of breath or the treatment of pain obviously contributes to fatigue, anorexia, nausea and vomiting, and very importantly, psychosocial concerns as well. So if someone presents with fatigue, there is a differential diagnosis to consider. She's currently working on a prospective analysis of our patient-reported elements of fatigue. And interestingly, a lot of our data that we receive from parents, even though parents aren't always sort of thought to be the best reported, is being validated by the children themselves. And this is Dr. Kira Bona, and her research is very much focused on understanding poverty and pediatric oncology outcomes, both the poverty that ensues from a cancer being treated for cancer, and whether or not coming into cancer care as a poor family or becoming poor as a result of cancer care results in different outcomes related to disease illness experience. So these data are simply showing that a lot of families lose proportions of their income, like greater than 40% of their income, even if you're from a relatively well-off federal poverty level. A high proportion of people in the sort of 200 to 400% of the federal poverty level also lose a high proportion of their income. But the poor suffer obviously the most and lose the highest proportion of their income. In a study that is currently in press, Kira has taken this work to the stem cell transplant patient population, showing the same findings of financial hardship that emerges from treatment in stem cell transplant, but importantly taking that one step further and showing that the higher risk of chronic graft versus host disease in children who come from poor families. And so the sort of association with these sociodemographic factors that can be mitigated, right? There are interventions to help support families through these cancer illness experiences are important to identify and to continue to work on. Oops. Okay, and this is Dr. Abby Rosenberg. She resides in Seattle, and she's doing a lot of work on resilience. one of her studies took some data from our parents of children who are being currently treated for advanced cancer and understanding their levels of psychological distress, so parent outcomes in pediatric advanced cancer, and showing that higher distress levels or lower distress levels are associated with different elements of the child experience. Again, just underscoring the family experience piece of cancer care or care of children with serious illness. So if parents perceive their child as suffering a lot or a great deal, they have a significantly higher psychological distress. If they're experiencing great financial hardship, higher psychological distress. If, however, their understanding of their child's prognosis is aligned with, we called it concrete goals or realistic goals, then their distress levels go down. So again, sort of suggesting some areas for intervention. And this is another analysis that Abby did on a long-term study of bereaved siblings, that these were siblings of children who had died over 10 years prior. And they were reflecting back on their experience as siblings of children who had died of cancer and looking at their trajectory over time. And in this graph, you see sort of the average score with regard to psychological outcomes, either anxiety or depression, the year before the child's diagnosis, average, the year following the sibling's death, very high levels, and then returning but not quite to normal compared to controls to a somewhat better level at long-term outcomes. And these patterns of anxiety and depression are associated with behaviors that are risky, like using illicit drugs and drinking alcohol. So what do these data suggest? Another area for support of siblings has to do with that year of vulnerability after the death of the child. This is Amy Dural, now Dr. Sanderson, who is looked at these issues from a provider perspective, because we know that certainly there are contributing factors to family factors that contribute to distress, and there are us provider factors that contribute to distress. And in Amy's study, she asked oncology clinicians and ICU clinicians, ICU and regular ICU and cardiac ICU and neonatal ICU, the question, what are the barriers to advanced care planning discussions, advanced care discussions for children with life-threatening illness? And again, these slides are not meant to be read, but just to signal me to tell you that the top 3 barriers from the perspective of providers is unrealistic parent expectations, differences between clinician and parent understanding of prognosis, and lack of parent readiness to have the discussion. What do these barriers suggest to you? These are physicians and nurses telling us why it's hard to have these conversations. I see you nodding your head. What does it suggest? We're holding parents responsible for these poor outcomes. It's not our fault, it's their fault. They're not ready. We have differences of understanding of prognosis. Why? Because we won't talk to them. They're not ready. They have unrealistic expectations. Of course they do. Does that mean we shouldn't still be holding compassionate and sort of important conversations? No. But we need to recognize that we're the ones that are creating these barriers. Anyways, moving towards intervention. So my question for you, how many people have kids? Raise your hand. Okay, or if you don't have kids, if you take care of kids. What's the most common response when you ask your child or your patient, how are you feeling? How was your day? Fine. It's universal. This is like a common human trait. You are born with the answer between like 8 and 18. Fine. You can't do anything about it, right? But the question is, what's behind the fine, right? Depressed, lonely, crying, scared, dying, lost, hurting, empty, anxious, broken, I'm lying. That's often behind the fine. So our prospective research, and this is my research partner, Dr. Veronica Dussel. Don't ask, but she lives in Buenos Aires. It's a whole other story, which we could have talked about this morning, but we're actually research partners. And we conducted the PediQuest study. PediQuest stands for Pediatric Quality of Life and Evaluation of Symptoms Technology. PediQuest was a computer-based data collection system that asked children to report on their symptoms and quality of life, and the system was able to generate feedback reports and email alerts to distressing symptoms. And our hypothesis was that increasing awareness of providers and parents about child symptoms and quality of life would decrease the child's experience of suffering, because we wanted to uncover, if we knew what was behind the fine, we would be able to do something about it. So we had 3 goals of this study. It was one of the things we were talking about again this morning was when you do research in small patient populations, you should use those subjects to the maximum and don't just ask one question. Don't burden them too much, but try and embed a few questions in one study because they're precious commodities. And so we wanted to see if it was feasible to do a randomized control trial in children with advanced cancer that was focused on a supportive care intervention. We wanted to describe the experience of child suffering from the perspective of the child and to explore determinants of child suffering. And then we wanted to preliminarily assess if routine feedback of the symptom and quality of life data using PediQuest would have any effect on the child's symptom and quality of life outcomes. So this is how we designed our study. We had the kids, and they were block randomized in three sites. We collaborated with Children's Hospital of Philadelphia and Seattle Children's. The control group answered at the time was a tablet computer where they were able to answer questions. It looks very old and archaic, but at the time it was kind of sexy. We used the instruments of the Pediatric PedsQL for quality of life measurement, a developmentally adapted Memorial Sloan Kettering assessment scale, and the FACES pain scale revised. And these kids went along and at most once a week or at least once a month they answered PediQuest, mostly when they came to clinic or in the inpatient setting, or if they were home for greater than a month, we called them. And we enrolled them for 3 months and said they could re-enroll every 3 months. And then in the intervention group, they did the same things as the control, but their providers and families got feedback reports. And we assessed satisfaction with the system, and then we combined the 2 groups to look at the overall experience of symptom distress. Okay, so I told you about the population somewhat. They had to be kids older than 2 because there were no developmentally adapted instruments for younger kids. And we were aiming for 120 families. So we opened up the study in 2005 and in 3 centers. And in 2009, we closed enrollment and had accrued 100 patients. So it's hard to accrue patients. This is sort of what the screenshots look like. We were most proud of this visual analog scale about overall sickness, not sick at all to very sick, but that the kids could just move it across the screen. And this is what the feedback reports look like. You were able to see scores in comparison to the last 5 times that the kid replied to PediQuest. And these are the domains of quality of life. So these are the average overall scores and then by domain. And then similarly, if a symptom was present, you could see how it compared to prior reporting and the domains of symptom distress, which included frequency, severity, and distress. And then when we piloted this report, the physicians basically said they want a summary, like an echo report, so we made a summary that said how the kid was doing relative to the time before. So just to share with you a few of our results. So is it feasible? Well, I already told you it took a long time to accrue patients, but when we were able to approach them, 70% or more, it was about 72% enrolled in the study. So without a gatekeeping, and I could talk about that in a minute, kids and their families enrolled in the study and stayed in the study to be able to, so the attrition was quite low once they were enrolled in the study. And the primary reason why we couldn't enroll kids is that there was issues around inclusion criteria, but only 21 of the patients of the original over 300 that were identified, physicians refused permission, but many died before we actually approached them. And then the consent process was cumbersome just to sort of tell them about the study, follow up with them, and we learned that we had to be much more efficient with that because we wanted to get them enrolled. But we were able to enroll. Now this is reasons for enrollment. We did a survey of families who chose to enroll and families who chose not to enroll. They didn't have to answer this survey, but look at the reasons why families enroll in these studies. To help other cancer patients and their families. And this is the children also answering these questions. The child decided, the relevance of the research topic. So a lot of altruism related to reasons to enroll, and reasons not to enroll, very practical, too much time or effort. The child decided. It was a true consent situation where if the child said no, then the answer was no. And then we asked parents, we did a small survey asking people why they stayed in the study. And this is a Wordle. The biggest words were the most commonly used in this qualitative answer as to reasons why they decided to stay in the study. To help other people. It was important. It was a study. It was for my child. And then there's this little thing here that says cards. We gave them gift cards. So incentives do matter also, but primarily, again, altruistic reasons for participating. And then what about kids' willingness to complete these surveys? We said to them if they didn't want to complete them, their parents could do it for them. 94% of the time out of 820 potential child administrations, the kid did it themselves. So they wanted to participate. They wanted to answer these questions. You give them a slightly different strategy than how are you feeling? They'll do it. What about the natural history of distress in children? Now remember, these are kids. This analysis is done over 9 months, and kids are reporting on a regular basis about how they're feeling with regard to specific symptoms and quality of life. And they're kids whose cancer has advanced beyond initial treatment. Some had much more advanced cancer, and some were very early on in their relapse of their cancer. And this is what we found, unfortunately. Again, this is the full cohort combining the intervention and the non-intervention arm and controlling for intervention. About 50% of time, children report that they're in pain, and a majority of that time, they're experiencing high distress from pain. 50% of the time that PediQuest is administered. Fatigue, remember the two most common symptoms from the perspective of parents? Again, almost 50% of the time, kids are having significant fatigue. And then all the symptoms we asked about showed up. And what about the psychosocial symptoms? Irritability, sleep disturbance, uncovering that our patients are not sleeping well, and the ripple effect of not sleeping well, not only on the child's well-being, but on the family well-being, is a critical area of intervention for us in palliative care. Now these data, the sort of second graph, are from the 75 surveys we had in kids that were done in the last 3 months of life. Okay, so these are sort of more end-of-life reports. And unfortunately, the proportion of children in pain goes up substantially from the voices of children themselves who are at end of life with cancer. So here we're at over 60% of kids with pain and about 50% of kids with fatigue, drowsiness, irritability goes up as well. So you could see that there's continued room for improvement in our symptom management in children with advanced stage cancer, not necessarily only at end of life. We looked at this is just I'll skip this, just average MSAS scores. But we looked at factors that were associated with high distress. So factors that were associated with higher total MSAS scores, higher physical MSAS scores, and higher psychological MSAS scores. And female gender is associated with higher total and psychological scores. The question for that is why? And it's natural to think that maybe girls are more vulnerable psychologically than boys, but the opposite might be true. They may be more free to report on their psychological distress. We don't really know. The other factors that were related were intensity of treatment. And that's not too unobvious, duh. The more intensive cancer-directed therapy you get, the higher your overall distress scores are across the board, okay? But it's important because this is treatment intensity in the 10 days that preceded the PediQuest administration, and it tells us that's when we have to pay attention to the kids' physical and psychological distress, that there's a relationship in terms of timing of treatment and time from last progression. The closer you are to a relapse, the more symptomatic you're going to be. Now, importantly, when we did an exploratory analysis of these same factors in kids at end of life, mild continued cancer-directed therapy was associated, and you can see a suggestion of this in the whole cohort, but it was significant, decreased psychological distress with continued mild cancer-directed therapy in children with cancer at end of life. So we learn a lot about how parents push to continue cancer-directed treatment and leave no stone unturned. And people ask the question to whose benefit. But I'm just suggesting here that these data from the children themselves suggest that there might be some psychological benefit to the kids also having continued cancer-directed therapy at end of life. And that's not the battle we should be fighting. We should be improving their symptom and quality of life, not worrying about whether or not they're on continued mild cancer-directed therapy. That's sometimes used as an outcome in the adult literature. You have good end-of-life care if patients don't receive chemotherapy in the last month of life. I think that that's a totally false measure of good quality end-of-life care, personally. And I think it's true for sure in pediatrics, and it's also true in adults. It's only when you're very, very, very old might that be sort of a poor outcome. But many of us, no matter how old we are, when we're trying to live a little bit longer, get some benefit from some continued cancer-directed therapy. And that's what these data are suggesting to me. Okay, lastly, what do you think? Does feeding back child symptom and quality of life data to providers and families make a difference in terms of their overall well-being? I heard good. I'm glad you hope so. We did too. But, well, one thing that we found was that kids valued the reports. They were easy to understand, and they helped me to talk to my doctor 50% of the time. And parents loved the reports. Think about this one. Almost all the time, the reports help me better understand how my child is feeling. To me, that's a positive outcome, if only to enhance the communication between the parent and the child themselves. What about providers? Well, the reports provided new information about psychological issues, like 60% of the time. They led to consulting specialists, depending on the specialist, up to 56% of the time. They were useful in speaking to patients 50% of the time. They didn't increase the consult time, good outcome. And they were somewhat to very helpful a majority of the time. But did they make a difference? The covariates I mentioned. This just shows you that at baseline there were no differences. And these are the results of the study. First of all, there are some findings that are positive, like The direction of symptom distress went down across all domains, but certainly not significantly. The improvement of quality of life, comparing the intervention to control, went up across all domains, but not significantly, except in subset analyses. It was particularly helpful for psychological well-being in the healthier children. And then overall sickness scores also improved, went down in kids who were healthier and older, I think is what that subgroup is. So some improvement, but not a home run. And I'll just say that to conclude this study, we know now that supportive care randomized controlled trials are feasible, but they take a lot of work, and there are some challenges with regard to numbers, and so multi-center studies are essential. That unfortunately, children with advanced cancer continue to experience many distressing symptoms, and often it's related to intensive cancer-directed treatment, so we know about the timing in which we have to pay greater attention. And feedback alone has some effect on child well-being, but can be strengthened. And the question is, why didn't feedback alone sufficiently improve symptom distress? Any ideas? Providers, something about the providers. You know what people said to me when they got an email alert that their kid was having nausea, continued nausea? I know, but I just don't know what to do about it. Right? And I may not have the time, or when they came in to visit me, though they mentioned the nausea, we had to talk about the treatment trial. And so I didn't have enough time to address the nausea. So the idea for our next study is to consider this intervention, which we're calling PediQuest Champions. We hypothesize that compared to feedback alone, if you combine feedback with intensive follow-up by a palliative care nurse practitioner champion who will be mandated to respond and embedded within oncology to respond, you will more effectively reduce child symptom distress. So that's the project that we're working on now. Anyways, we've developed the PediQuest web platform, so kids are now using it online, and we're in the midst of developing a PediQuest app to be used on smartphones as well. And this is our enhanced report too, which not only will show you trajectories over time, but we'll be able to track treatments that the child has had in proximity to the PediQuest report and put in the medications that they're currently on. And so back to the principles of pediatric palliative care, to end with just a note about self-care in the context of all of our hard work. I think that it's important to be a role model in self-care and to sort of guide my teams both clinically and from a research perspective to prioritize self-care. And we had a long talk about that this morning too, whether or not you should cry when you're pregnant because you're having a baby and how it will disrupt your research career. The answer is no, you should be celebrating, just putting it out there. But also, self-care is about living well and also to recognize the important life lessons that we all discern from this amazing work. So as Lori Moore once wrote, another mother, the mother of Eric, comes up to them. It's all very hard, she says, her head cocked to one side, but there's a lot of collateral beauty along the way. Thank you.
We still have a few minutes for questions.
Yes.
The families seem to like the report so much, and I'm sorry if I missed this, but did you do any measurements of parent well-being or satisfaction?
No. I mean, we have satisfaction with the reports, but great to look at in follow-up studies about their own, that whole sort of measure of their distress outcomes and whether or not that is in some way related to a better sense of knowledge of how their child is feeling. It's a great idea.
Hi, I'm an adult oncologist, and I just wanted if I could challenge you on your statement about
Everybody always does. Yeah.
do you really think that even mild, so-called mild chemotherapy at the end of life is the best way to palliate what is really a set of psychological symptoms?
I think it's an option. I just don't think it should be, forbidden, let's just say. And the outcome of an informed, compassionate conversation may or may not include continued cancer-directed therapy, but it just shouldn't be completely taken off the table. I just think we sort of focus so much on that as an important sort of measure of how well we're doing.
It's awfully hard to find data to suggest that really end-of-life chemotherapy benefits patients in any way.
Except for my data.
Well, except precisely my point. Honestly, that's precisely my point, that there are actually other ways, of course, of palliating psychological symptoms.
Yeah, it's not a...
involve chemotherapy.
That's correct. I'm not at all arguing with you, and I'm a palliative care physician, and I believe strongly in intensive psychosocial support. I think that we don't even know yet the nuances of those interventions that can make the biggest difference. But I just don't think that we should be measuring whether or not continued chemotherapy is continued as an outcome of how well we're doing.
Because I think there's a great opportunity cost, not to belabor the point, is that we often, on our side, use the end-of-life chemotherapy as a substitute, actually, for dealing with the psychological distress. Because it's actually the easiest intervention.
Possibly, yes. I think that for sure it's a default intervention. But it's also an opportunity to expand the conversation if you can get past the question of chemotherapy and be able to make a difference beyond that particular decision. So there's lots of ways to cut this. I think that there's also a lot in pediatrics that suggests that we're treating the parents when we continue cancer-directed therapy. And I think that it's a misconception to always be thinking about the child as separate from the parents, because they're a unit, and disrupting that unit isn't either the goal of what we're trying to do at end of life for these kids. We want to keep families intact at the time of a child's end of life care and well beyond it. I love the conversation.
I think we have time for
Excellent talk. I'm a pediatric oncologist, and I have kind of two questions.
Mm-hmm.
Just from your PDQuest data, and we also see in our practice that there's a lot of psychological distress.
Mm-hmm.
But how do you leverage your healthcare team to really get the input of the person who can intervene on those distress? As an example, at our institution here, we don't have a pediatric psychologist
Mm-hmm.
who can really take care of the psychological piece.
Mm-hmm.
And we have let away a lot of our social workers in the last 2 years itself. We've gone from 6 social workers to 2 who are then, so we clearly have no expertise to deal with the psychological piece. And then on the flip side, from a symptom and distress piece, we really don't have effective medical therapies to really deal with fatigue, with anorexia, with, difficult nausea, vomiting, and we struggle with that. So
Yes.
I'm not sure if, even if you have the best nurse practitioner who's championing everything via telephone, unless we have those tools.
Okay, let me ask you a question. So yes, I agree. There's a lot of challenge. One is that I think that we need to move beyond the psychosocial clinician alone as the intervention strategy for psychological distress in families facing cancer treatment. For example, Abby's and other people are working on sort of targeted interventions like resilience training as a way to, it doesn't have to require routine visits even with a psychosocial clinician, but if you put every patient that comes through your clinic through some sort of resilience training, if it's proven to be something that helps them to frame their illness experience in a more psychologically healthy manner. So that's an area of work that this whole field needs to continue to explore. We don't have the answers that you're asking for, nor do we always know about the best way to ease a distressing symptom. However, I would suggest that there's ways to improve it. So, for example, as my pediatric oncology hat is on, I might write a prescription for an opioid, and I'll say to the family, call me if it doesn't work, okay? If I'm wearing my palliative care hat on, I'll write a prescription for an opioid, and then I will call them 24 hours later and check if it's working. I'm not going to wait till they follow up with me or come back to clinic the following week to know that they suffered for 4 days instead of 3 days. We have to chip away. We have so many complementary strategies. I see the back row nodding, yes. How much, to have offered a boy who was having refractory nausea a little orange flavored inhaler that he clung to because it made him feel so much better, that's better than never offering it at all. We don't know all the ways in which we're going to chip away at the suffering. It's not going to be a magic bullet, but if we don't embrace that as an area of investigation, then it will never happen. So that's my answer. Full disclosure, palliative care. Introduce yourself.
So I'm the new program director for the integrative medicine for pediatric palliative.
And your name is, so if you want to find you.
From New York. So what we've been doing is working very closely with child life.
Mm-hmm.
And we rely on them quite heavily, and they are such an incredible gift. And we find that sometimes when the white coats have left the room, these conversations will come up.
Yep.
And this relieves the stress, in my experience, time. And again, it's beautiful. And my sense is that everyone is responsible for the psychosocial moment of things.
Yeah, and you have to learn how to recognize opportunities to further conversations. It might happen with the doctor, right? So we have to be able to handle it. So
I think the other piece of that is that the deliberatively addressing those things early. And to me, it's the preventive things.
Mm-hmm.
What are the strengths that families bring, and then helping them to reflect on those strengths and how they can use them in their cancer journeys or whatever. Thank you very,
you're
very
welcome.
much.
Thanks for having me.